When you think about injecting like a cosmetic filler, I imagine you probably picture something akin to a plush couch cushion. You have this soft, pliable space, you add some volume to plump it up, and everything just naturally expands to make room.
Right. It's a very predictable, almost comforting idea of how our bodies work, you know? A yielding space just welcoming a little extra padding.
Exactly. It implies that human tissue is essentially an empty, accommodating canvas, just waiting patiently to be contoured.
The fundamental assumption there is tissue compliance. That's the idea that the physical structure will easily stretch and accept whatever you put into it without, fighting back.
But consider what happens when you take that exact same plush cushion, violently rip out the stuffing, sew the fabric together as tightly as possible with heavy-duty thread, and then reinforce the whole thing with a stiff layer of synthetic plastic mesh.
Yeah, that changes the physics entirely.
Right. And then after all of that structural trauma, someone comes along and tries to inject that exact same cosmetic filler into it.
You are no longer dealing with a soft cushion at that point. You are trying to pump fluid into a rigid, impenetrable wall of scar tissue. And functionally, structurally, that alters everything about how a medical procedure is going to behave.
Welcome to the deep dive. Today we are looking at a bizarre and honestly fascinating anatomical collision. We've pulled a really diverse stack of sources for you today.
We've got surgical textbooks like GLOWM, peer-reviewed histological studies on mesh complications, and clinical guidelines.
Yeah, specifically from the American College of Obstetricians and Gynecologists, or ACOG. And we're also looking at marketing materials directly from cosmetic clinics.
And just a quick note right off the bat before we get into the weeds, elective cosmetic procedures like the ones we were discussing are highly controversial.
Heavily debated in the medical community. And we aren't here to take sides, endorse a viewpoint, or, judge anyone's choices.
Not at all. We're just acting as your guides to the blueprints of the human body to see what actually happens when reconstructive surgery violently collides with cosmetic enhancement.
Our mission today is to focus on the mechanics. We want to unpack how a reconstructive surgery fundamentally and sometimes permanently alters the specific anatomical plane that a cosmetic injection absolutely relies on.
So to understand that collision, we have to start by looking at the target itself. Let's talk about the geography of the G-spot and the cosmetic procedure designed to enhance it.
Right, where exactly are we aiming?
Well, the term G-spot originates from the work of Ernst Grafenberg, who is a German gynecologist. He published a paper way back in 1950 describing a highly sensitive erogenous zone.
And geographically, we are talking about the anterior or front vaginal wall.
Exactly. If you are visualizing the anatomy, it's located about 1 to 3 inches, so 2 to 3 centimeters inward from the vaginal opening, sitting right beneath the urethra.
I noticed in the sources, though, that the exact anatomical structure of this spot is still fiercely debated by scientists. It's not like a distinct organ you can just easily dissect and point to on a chart.
No, it's really not. Some researchers describe it as a neurovascular complex. Others say it involves the urethral sponge. But clinically, patients consistently report this specific area on the anterior wall as a zone of heightened sensitivity.
Which is precisely why it became the focus of cosmetic intervention. Cosmetic clinics offer a procedure commonly marketed as the G-shot, or a G-spot amplification.
And the clinic materials we reviewed, they describe this as a very quick, elective, non-surgical office procedure.
Yeah, they say it takes about 10 to 15 minutes total. The patient is positioned similarly to how they would be for a routine pap smear.
Right, and the clinician uses a specially designed speculum to access that anterior wall, and a local anesthetic is applied to numb the tissue.
Then comes the injection. Once the area is sufficiently numb, the clinician injects a small volume of filler directly into the submucosal layer of that anterior vaginal wall.
Typically, they're using hyaluronic acid fillers, or HA, and this is the exact same material used in dermatology to plump facial wrinkles or lips.
Occasionally collagen or autologous fat is used, but HA is definitely the standard. The volume they inject is usually between 1.5 to 4 milliliters.
Okay, let's actually unpack this for a second. If you go back to that couch cushion idea, injecting 4 milliliters of gel into a soft, delicate submucosal layer relies entirely on how hyaluronic acid actually works.
HA is basically a moisture magnet, right? It just binds to water.
It binds to a massive amount of water. Hyaluronic acid molecules can hold up to 1,000 times their weight in water.
Wow, 1,000 times.
Yeah. So when it's injected into a pliable tissue plane, it creates a temporary localized pool of fluid. It literally balloons the tissue outward.
And the marketing materials state that this creates a localized cushion that enlarges the G-spot to about the size of 1/4 in width and 1/4 inch in height.
The mechanical goal is straightforward. By increasing the physical volume and projection of this sensitive area, it theoretically increases friction and sensory input during sexual activity.
Right, it creates a much more prominent physical target within the vaginal canal.
And because the body naturally metabolizes hyaluronic acid over time, that quarter-size cushion is temporary. The clinics note that the effects typically last for 4 to 6 months.
But the entire premise of this procedure, like the very physics of it, relies on finding a pristine, pliable, healthy pocket of tissue that can easily stretch to accommodate and hold that fluid filler in place.
That is the absolute key. It needs compliance.
So we have this idealized picture of a pristine plumping procedure. But when I was looking through the ACOG guidelines in the surgical textbooks, I realized that for a massive number of women, this pristine canvas doesn't even exist.
No, it really doesn't.
Because that specific structure of the anterior vaginal wall is actually prone to a catastrophic collapse. How does that even happen?
Well, to understand the collapse, you have to look at the underlying architecture. The anterior vaginal wall isn't just a floppy tube of skin, it's a trapezoidal plane, and it is supported by a remarkably strong layer of connective tissue called the pubocervical fascia.
Okay, pubocervical fascia.
Yeah, you can visualize this fascia as a dense, fibrous trampoline, or like a structural floor that stretches horizontally across the pelvis. Crucially, this floor serves a major purpose. It supports the bladder, which sits right on top of it.
Wait, I'm having a little trouble visualizing this. If this pubocervical fascia is as strong as a trampoline, how does the bladder just drop through it? Is the tissue physically tearing like fabric, or is it just sagging under the weight?
It can actually be both, depending on the trauma. The sources point out that factors like vaginal childbirth, the hormonal changes of menopause, normal aging, and even simple genetics can degrade the collagen in that fascia.
Right, just wear and tear over time.
Exactly. The physical physics of it are heavily tied to intra-abdominal pressure. Every time you cough, sneeze, or lift something heavy, you are pushing downward on your internal organs.
So over time, or during a traumatic event like childbirth, that fascia can literally rip. The textbooks describe two main types of tears, right?
Yeah.
Yes. It can detach from the pelvic sidewall, which surgeons call a perivaginal defect, or it can tear straight down the middle like a zipper breaking, which is a midline defect.
And when that firm connective tissue gives way, gravity and abdominal pressure take over.
Yep. The bladder basically falls through the broken floor and bulges down into the vaginal canal. This specific type of hernia is called a cystocele.
The numbers in the sources regarding this condition are absolutely staggering to me. It is estimated that 80% of all surgical repairs for vaginal wall prolapse involve this anterior compartment. 80%.
It is overwhelmingly the most common site of initial pelvic organ prolapse. The anterior wall simply bears the brunt of the anatomical load.
So if the very floor the bladder sits on gives way and tears, that completely changes the landscape of that anterior wall we were just talking about with the cosmetic procedure. The canvas for the G-shot is basically caving in on itself.
Completely. The wall is no longer a smooth, tight, yielding plane. It is a bulging, stretched, structurally compromised hernia. The tissue is thinned out and weakened. And fixing a cystocele requires incredibly aggressive surgical intervention. This is where the natural anatomical plane for a cosmetic injection is systematically obliterated.
Let's follow this into the operating room. How do surgeons physically rebuild a collapsed bladder floor?
The traditional, time-tested surgical fix is a procedure called an anterior colporrhaphy. The mechanics of this are pretty intense.
Yeah, reading about it was wild.
The surgeon begins by placing 4 surgical instruments, Alice clamps on the anterior vaginal wall. They use these to pull the tissue in opposite directions, forcefully stretching the vaginal wall out into a tight diamond shape just to get tension on it.
And once they have it stretched tight, they take a fresh scalpel and make a full thickness incision. The GLOWM surgical textbook describes this so vividly.
They cut right down the middle of the anterior wall, starting roughly 2 to 3 centimeters from the urethral opening, which, geographically, is exactly where the G-spot is supposed to be.
Right, and they cut almost all the way to the top, or the vault, of the vagina.
The next step is a deep tissue dissection. The surgeon has to separate the superficial vaginal skin, the epithelium, from those underlying vesicovaginal connective tissues. They literally strip the layers apart.
By force.
Yeah, often they use blunt dissection, which means wrapping their finger in surgical gauze and forcefully pushing the tissue planes apart to shove the prolapsed bladder back up into the pelvic cavity where it belongs.
Okay, so the bladder's out of the way. Now they have a broken floor that they need to fix.
They fix it through a process called plication. They locate the edges of that stretched, torn fascia from the sides, bring them together in the midline, and suture them tightly.
Plication meaning they are essentially taking the slack out of it, like taking a loose pair of pants, folding over the excess fabric, and pinning it tightly to make the waist smaller.
That is a perfect analogy. They are pulling the torn edges of that trampoline back together and sewing them overlapping and tight to create a rigid, reconstructed floor to hold the bladder up.
And they use heavy, permanent, or delayed absorbable sutures to ensure it holds against future abdominal pressure.
Exactly. And because the vaginal skin itself had stretched out over months or years to accommodate the bulging bladder, there is now way too much skin left over.
If they just sewed it closed, it would be a loose flap.
Right. So the surgeon physically takes scissors, trims away the excess vaginal wall, and then stitches the whole primary incision tightly closed.
The surgical goal is purely structural. They need to reduce the caliber of the vagina and provide a rigid, unyielding support system so the bladder doesn't herniate again.
Here's where it gets really interesting. If you picture what just happened mechanically, the implications for a cosmetic injection are profound.
Oh, totally. By cutting that wall wide open with a scalpel, forcefully stripping the tissue layers apart with blunt force, pulling the deep fascia tightly together with heavy sutures, cutting away the excess tissue, and sewing the skin back up, that delicate, soft, submucosal pocket where a G-shot filler is supposed to sit, it simply doesn't exist anymore.
It really doesn't. It has been radically altered into a tightened, sutured, scarred surgical plane.
The tissue architecture has been permanently changed. You've replaced a natural, yielding tissue matrix with a rigid, dense scar line.
But in modern reconstructive gynecology, the anatomical alteration doesn't always stop there, because traditional anterior colporrhaphy, just sewing the native tissue back together, actually has a remarkably high failure rate.
Right, because if the patient's native tissue was weak enough to tear in the first place, relying on that same weak tissue to hold or repair seems risky.
Exactly the problem. Suture weak tissue to weak tissue under high tension, and the cystocele often comes right back. Some of our sources note failure rates for traditional native tissue repair as high as 30 to 40%.
Wow, that is high.
So, to combat this high recurrence rate, surgeons began reinforcing the anterior wall repair with implants, specifically synthetic polypropylene mesh.
And this is where the histology, the microscopic study of how tissue behaves from our sources gets absolutely fascinating. When a surgeon implants a piece of synthetic plastic mesh into the anterior vaginal wall, the body doesn't just passively accept it like a structural beam in a house.
Not at all. The human body is incredibly hostile to foreign materials. The moment the mesh is implanted, it triggers an immediate, aggressive, foreign body reaction.
The immune system basically flags the polypropylene as an invader.
Yep. White blood cells called macrophages swarm the area, specifically infiltrating the tiny woven fibers of the mesh.
I really want to dig into the mechanics of this immune response because the peer-reviewed studies highlight two specific subtypes of these cells, M1 and M2 macrophages. Why do we care about the difference between M1 and M2?
Because they represent a permanent biological tug of war. M1 macrophages act like the aggressive attack phase. They flood the tissue and release inflammatory cytokines, trying desperately to break down and eat the plastic.
But they can't degrade synthetic polypropylene, can they?
No, they can't. So the body stays in a state of chronic, ongoing inflammation. Realizing the invader can't be destroyed, the immune system calls in the M2 macrophages.
And the M2 cells are basically the builders.
Yeah.
Right.
Yes. The M2 macrophages try to isolate the threat by walling it off. They stimulate fibroblasts to lay down massive amounts of thick collagen scar tissue.
So they just build a wall around it.
Exactly. This forms an internal granuloma around the individual plastic fibers and builds a dense external fibrotic capsule around the entire mesh implant. It essentially entombs the plastic in a biological cage.
And the physical properties of the mesh itself dictate just how severe this biological response is. The sources show that if the mesh has small pores, specifically pores less than 1 millimeter in size, the microscopic scar tissue fills in all those tiny, empty spaces.
And scar tissue doesn't just sit there. As it matures, it actively contracts.
It shrinks. And as that microscopic scar tissue inside the pores contracts, it physically pulls on the synthetic mesh. It causes the implant to deform, fold, and become incredibly stiff.
What's fascinating here is that the immune system's attempt to heal the area and wall off the invader actually destroys whatever natural elasticity was left in the vagina.
What was once a pliable, muscular, flexible mucosal wall degenerates into a rigid, fibrotic, synthetic biological scar plate.
You are left with a composite tissue matrix that behaves more like stiff leather or a piece of tire rubber than flexible muscle and mucosa.
Which brings us to the ultimate intersection of this deep dive. We have to synthesize what this means when the worlds of cosmetic plumping and structural reconstruction collide. Imagine a patient who has had this complex reconstructive history sitting in a clinic reading a brochure about a 15-minute G-shot procedure.
The fundamental clash here is one of physical space and fluid dynamics. The G-shot, by its very definition, relies on finding a soft, natural, yielding submucosal plane on the anterior vaginal wall.
It needs that flexibility. The hyaluronic acid has to expand. It needs a place to go to create that fluid cushion of 2 to 4 milliliters.
But if you are a patient who has had an anterior colporrhaphy, that natural plane has been obliterated. It is filled with dense scar tissue and tight suturing right at the exact geographic coordinates the cosmetic clinician is aiming their needle at.
And if you have had a synthetic mesh placed for a cystocele repair, the situation is even more extreme. That plane is completely blocked by a solid wall of encapsulated, contracted, stiff synthetic material and intense fibrosis.
Let's break down the mechanics of what happens if someone actually tries to inject into that. What does this actually mean for the patient?
Mechanically, trying to force a volume of thick gel filler into a non-pliable scar plate or a rigid mesh matrix is completely different from injecting virgin tissue. The fluid simply has nowhere to go. It cannot easily expand into a nice, neat, quarter-sized cushion.
It's like trying to inject water into a concrete block instead of a sponge.
That is a very apt comparison. When you inject fluid into a space that cannot expand, the pressure inside that tissue spikes rapidly.
Theoretically, trying to forcefully expand heavily scarred or mesh-infiltrated tissue increases the risks of severe complications.
The scarred tissue doesn't have the robust blood supply or the natural elasticity to accommodate the physical trauma of the injection needle, let alone the volume of the expanding filler.
And this mechanical reality provides incredible context for the clinical guidelines we mentioned earlier. The American College of Obstetricians and Gynecologists, ACOG issued Committee Opinion Number 795, which explicitly warns against these cosmetic vaginal procedures.
ACOG notes a profound lack of high-quality data regarding the safety and effectiveness of procedures like the G-shot. They take a very firm stance that women must be thoroughly counseled about potential complications.
And when you look at the list of complications they cite, infection, severe scarring, altered sensation, and dyspareunia, which is painful intercourse, they suddenly make total sense.
Right. When you understand the underlying anatomy, when you visualize a needle trying to force an expanding cosmetic filler into a surgically altered, heavily scarred, or mesh-reinforced anterior wall, those medical warnings leap off the page.
It's not just a theoretical risk. The risks of creating intense chronic pain from pressure, triggering a renewed inflammatory response around an old mesh implant, or even physically disrupting a fragile surgical repair become highly logical, mechanical consequences.
It is a profound collision of intentions. We started this deep dive looking at a simple 15-minute cosmetic injection designed to effortlessly plump a pristine patch of tissue to enhance pleasure.
But when we pulled back the layers, we found the structural reality of pelvic floor collapse.
We saw how the brutal yet necessary mechanics of tearing down and suturing up the vaginal wall to stop a prolapsing bladder permanently alters the landscape. The immune system's fibrotic response to mesh leaves behind a rigid barrier in the exact millimeter of space a cosmetic needle wants to go.
It perfectly illustrates why a seemingly simple cosmetic enhancement cannot ever be divorced from a patient's complex surgical and anatomical history. The blueprints have been completely redrawn.
But before we wrap up, we promised you a final twist from the sources. And this one might just rewrite the entire premise of the cosmetic procedure to begin with, rendering the entire conflict totally moot.
This raises a massive structural question about the G-spot itself. We mentioned earlier that the anatomy is debated. Well, several researchers in our sources point out that the anterior vaginal wall might not possess a unique standalone spot of highly sensitive tissue at all.
Instead, they argue that the sensations attributed to the G-spot are actually just the internal underlying structures of the clitoris, so the clitoral bulbs and the urethral sponge pressing against the vaginal wall from the inside.
So it's not the wallpaper that's sensitive, it's the plumbing behind the wall.
Exactly. And one of our sources, a plastic surgeon named Dr. Colin Moore, takes this anatomical argument a step further. He argues that if the sensitive erectile tissues are actually located much deeper, closer to the urethra than the superficial vaginal skin, then injecting a cosmetic filler directly into the submucosal layer of the vagina is anatomically incorrect.
Dr. Moore suggests that placing bulking material in the shallow vaginal wall doesn't push the sensitive tissues outward to make them more accessible, it just pads the wall. It actually adds a layer of insulation between the vaginal canal and the nerves.
Wow, so it's doing the opposite of what it's supposed to,
Right. Instead, he advocates for a transurethral approach.
meaning injecting through the urethra.
Yes, injecting a permanent bulking agent underneath the muscles of the urethra itself to physically push those deep internal erectile structures downward toward the vaginal canal so they can actually be stimulated during intimacy.
So what does this all mean for you, the listener? It leaves you with a truly fascinating and somewhat ironic question to ponder. Let's say Dr. Moore is right, and the true source of that sensation is rooted much deeper, near the urethra. If a patient had a cystocele repair, did the stiff, impenetrable wall of dense scar tissue and synthetic mesh permanently block that physical connection?
It's entirely possible. You have created a literal structural barrier of fibrosis between the vaginal canal and the deep nervous system.
And if that's true, does it mean that no amount of cosmetic filler desperately pumped into that rigid, reconstructed surface wall could ever bridge that gap again? Because you aren't fixing the connection, you are just injecting expensive gel into a numb wall of scar tissue. It's a wild paradigm shift, and definitely something to think about next time you assume a space in the human body is just empty, pristine, and waiting to be filled.